You are evaluating a 67-year-old man who has just arrived in the emergency department. Minutes ago, he lost all ability to move his mouth. Look at this clinical presentation. The patient is awake and alert, but he suffers from acute anarthria, an absolute inability to speak, coupled with severe dysphagia, meaning he cannot swallow. When asked to follow basic commands, the deficits are striking. He cannot protrude his tongue, he cannot close his eyes tightly, and he cannot puff out his cheeks. The voluntary pathways are completely unresponsive. But then, you notice a paradox. As his family speaks to him, a joke is made, and he spontaneously smiles. When he becomes distressed, he cries, and normal facial expressions return. This specific presentation, complete failure of commanded action, alongside perfectly preserved emotional expression, indicates this is not standard muscle fatigue or a peripheral nerve palsy. The muscles work, the commands do not. This diagram maps the dual-state face. On the left, we see the severe voluntary deficits, the paralyzed jaw, the immobile tongue, and the unresponsive pharynx. On the right, the automatic functions remain intact. The patient can still yawn, cough, and exhibit genuine emotional responses, like laughter or grief. Through all of this, the patient's cognitive comprehension remains entirely intact. He understands everything being asked of him, separating this condition entirely from aphasia. This definition slide outlines the diagnosis: Foix-Chavany-Marie Syndrome, also known as bilateral anterior opercular syndrome. This equation summarizes the logic. When you observe severe voluntary paralysis of the face, tongue, and pharynx, but see emotional movement surviving via intact lower cranial nerves, it points directly to a bilateral anterior operculum lesion. To understand why this dissociation happens, we need to trace the physical wiring of voluntary movement back to its source. Here is the origin point. The frontal operculum serves as the critical checkpoint generating voluntary orofacial commands. From here, the corticobulbar tract acts as the descending highway, carrying precise instructions down to the lower cranial nerves controlling the face, jaw, and larynx. This schematic shows exactly where the breakdown occurs. Damage to the operculum creates a supranuclear block. The cortex attempts to send the command, but the connection is severed before it ever reaches the brainstem. Because this damage occurs high in the motor pathway, it isolates the upper motor neuron failure from the lower motor neurons. The peripheral hardware is simply waiting for a signal that never arrives. This diagram details a critical neuroanatomical rule: redundancy. Lower cranial nerves receive input from both sides of the brain. If one side suffers a lesion, the intact hemisphere automatically compensates. Therefore, Foix-Chavany-Marie Syndrome requires bilateral injury to completely sever voluntary communication. Because of this built-in evolutionary redundancy, knocking out all voluntary bulbar function is rare. It requires a highly specific two-part structural collapse. In clinical practice, this dual collapse rarely happens in a single event. It is usually the result of sequential vascular injuries. This timeline illustrates the trap. In the past, an asymptomatic infarct occurred in one perisylvian territory, going unnoticed due to redundant wiring. Then, a new acute infarct strikes the contralateral side. This second stroke destroys the backup, instantly unmasking the syndrome. A sudden presentation of this total motor lockout in an adult almost always indicates that an acute stroke has finally triggered a pre-existing silent defect. This brings us back to the initial paradox. If both voluntary highways are destroyed, how does the patient manage to smile? Returning to this flowchart, notice the bottom row. Because the bilateral block is supranuclear, the lower cranial nerves themselves, controlling the jaw, face, and tongue, are perfectly healthy. This diagram maps the parallel circuitry explaining the phenomenon. The brain possesses a separate network for emotional expression. These automatic movements originate deep in the limbic centers, descending directly through the brainstem to activate facial musculature, entirely bypassing the damaged opercula. The patient has not lost their muscle function. They have lost their voluntary command language. Their primitive emotional language remains hardwired, accessing the muscles through a backdoor circuit. In an emergency setting, this precise mapping is critical, because this presentation mimics other severe neurological crises. This comparison table separates the clinical lookalikes. While aphasia involves a failure of language formulation or comprehension, Foix-Chavany-Marie is a pure motor disconnect. The patient's language centers are intact. It must also be distinguished from locked-in syndrome, which stems from a ventral pontine lesion and results in near-total paralysis, notably without the sparing of emotional facial expression. The critical bedside discriminator is a simple request. Ask the patient to smile. They will fail on command, but a spontaneous, natural smile may appear when family enters the room. Confusing this pure motor lockout for aphasia delays the recognition of the precise vascular territory involved. Diagnosing it as locked-in syndrome incorrectly locates the lesion in the brainstem, misunderstanding the patient's actual physical state. This clinical protocol lists the immediate action plan. The exam must specifically test for this dissociation, comparing commanded facial movements against spontaneous emotional reactions like laughing or yawning. The most critical safety intervention is establishing a strict NPO status. Because voluntary swallowing is paralyzed, giving the patient anything by mouth carries an extreme risk of aspiration. From there, clinicians need to rapidly secure MRI or CT vascular imaging to map the acute secondary lesion and initiate early speech and language therapy to establish alternative communication. As noted here, using a general term like aphasia is a clinical error. The silence of the tongue, pharynx, and face is a profound motor failure, occurring even though the patient's underlying language centers are fully functional. This complete model visualizes the reality of the syndrome. The voluntary pathways are severed, while the automatic, emotional pathways endure. By identifying this distinct bedside dissociation, a locked mouth capable of a living smile, you can immediately localize the injury to the bilateral cortices, implement correct safety protocols, and accurately communicate with a patient who is fully conscious, yet physically trapped by their own motor circuitry.